Good day to you all. My name is Dr. Mvundura, second year resident in OBGYN, currently attached at Fetal Medicine, Salim Mugabe. Today I'll be presenting a case of fetal tachyarrhythmia. My presentation will be in two parts. The first part will be a brief overview of fetal arrhythmias. Then I will end by presenting a case that we managed at Salim Mugabe. So fetal arrhythmias are deviations from the normal fetal heart rhythm, which is characterized by a regular heart rate of 110 to 180 beats per minute. Some sources, they quote 160 beats per minute. Fetal bradycardia is defined as a fetal heart rate which is below 110. Fetal tachycardia is a fetal heart which is above 180 beats per minute. So abnormalities in fetal heart rate and rhythm occur in about 1% of all pregnancies. 10% of the arrhythmias are associated with potential morbidity and mortality, while the rest are benign. An estimated prevalence of tachycardia is 1 in 100 to 200 pregnancies. Then locally, in a cohort of 2,700 scanned pregnant women at fetal medicine, only about 0.1% had arrhythmias. One possible explanation is that we may be underdiagnosing fetal arrhythmias. So this is just the anatomy of the heart, focusing on the conduction system of the heart. So we've got the sinoatrial node, the atrioventricular node, the bundle of His, the left bundle branch and right bundle branch, and the Purkinje fibers. So the sinoatrial node is the one that initiates each beat, which goes to the left atrium, then to the AV node. The AV node, there is a bit of a delay in conduction in the AV node. This allows for the atria to contract first, so that the ventricles get filled before they contract. Then the conduction goes via the bundle of His, then the Purkinje fibers to the rest of the heart. Of note, there is the fibrous skeleton of the heart prevents re-entry of the impulse from the ventricles back to the atria. So this anatomy is important for us to understand fetal arrhythmias. To understand fetal arrhythmias. So we've got so the conduction system is made up of specialized cardiomyocytes, and there are problems with ion channels. There may be problems with cardiomyocyte coupling that may end up resulting in arrhythmias. I'll give an example of the Wolff-Parkinson syndrome, where there is pre-excitation of the ventricular myocardium via an accessory pathway, which conducts faster than the AV node, so there won't be that delay. In the developing fetus, initial beating is noted between 3 to 4 weeks, and at around 5 to 6 weeks, the SA node begins its function with a rate of between 100 to 120 beats per minute, and it peaks at 9 to 10 weeks at around 170 to 175 beats per minute. Then it gradually falls to settle between 110 to 160 beats per minute. This gradual falling is attributed to the development of the parasympathetic system. This is important to understand that when we interpret these fetal heartbeats, we should also put into consideration the gestational age of the fetus. To diagnose fetal arrhythmias, we do fetal ultrasound scan, where fetal echocardiography is done. Cardiac electrical activity can then be inferred from ultrasounds, temporal mapping of mechanical events. It's difficult to do an ECG in a fetus because of the interference in electrical activity between the mothers and the fetal heart. So when we examine the fetus, we do pulse Doppler, also do the M mode, we do tissue Doppler imaging. There's also a novel technique where fetal magnetocardiography can be done. This can map out the fetal electrical activity without much interference. However, it's very expensive and it's not readily available. So when we are sampling the fetal heart rate, we have to use a gate of about 2 millimeters, and the optimum site for us to get a wave that we can actually analyze, we have to put our gate below the AV valves. That is to pick up ventricular inflow and outflow. So the fetal heart rate pattern looks like this. It has got a wave that represents a ventricular inflow, that is atrial contraction, and it has got another wave. It has got another wave that represents a ventricular contraction, that is the outflow. On the ventricular inflow, we've got the E wave and the A wave, and from that you can do measurements that can give us an idea of the PR interval, which is analogous to the PR interval when we are doing the ECG. So in a normal sinus rhythm, we must have an atrial contraction first, which is followed up by a ventricular contraction. Fetal arrhythmias can be classified into bradycardia and tachycardia. Bradycardias, we've got sinus bradycardia, a blocked atrial bigeminy, and atrioventricular block. Then on tachycardia, we can have a sinus tachycardia, supraventricular tachycardias, that can be further classified into short VA or long VA, supraventricular tachycardia. We can also have atrial flutter. Then we have a ventricular tachycardia. So sinus bradycardia, we've got maternal and fetal causes of sinus bradycardia. Maternal causes, they include hypothyroidism, they include use of drugs like beta blockers, magnesium sulfate, and anesthetic drugs, and also maternal hypotension. Then on the fetal side, you can have a sinus node dysfunction, fetal hypoxia, fetal distress, central nervous system abnormalities, and channelopathies that may cause a long QT interval. So this is an example of a blocked atrial bigeminy. Generally, it's a benign transient arrhythmia characterized by a coupled pattern of a normal beat followed by a premature blocked atrial beat, causing a slow fetal heart rate. If we look at this fetal heart rate depiction, where it's written PAC there, that's a premature atrial contraction. We can see the wave is actually different from the other waves, where we have an E wave first, then an A wave, which is followed by a ventricular contraction. However, this first premature atrial contraction was followed up by a ventricular contraction. Was followed up by a ventricular contraction. But if you look at the second wave, there's a skipped ventricular contraction. So that's when we have a blocked premature atrial contraction. This is another example. I'm sorry, the picture is not clear, but here we can see again the atrial contraction is above the baseline, and the ventricular contractions are below the baseline. Where we have a PAC there, that's the premature atrial contraction, it is not followed by a ventricular contraction. We've got a blocked beat there, which may give us an appearance of a bradycardia. Then another cause, we've got atrioventricular block. The AV node, so the AV node has got a faster beating rate as compared to the ventricular, as compared to the sinoatrial node has got a faster beating rate compared to the ventricular, the VA node, the AV node, sorry. The AV node has got a rate of about 40 to 60 beats per minute, whereas the SA node has got a rate of 60 to 100 beats per minute. That is in extrauterine life, but in utero it can go up to 120 beats per minute. So if there's complete block, we only have the ventricular rate, which is slower, causing a bradycardia. So in atrioventricular block, we have got a ratio which is greater than 1:1. That is, the atrial rate is higher than the ventricular rate because it is not fully conducted to the ventricles. We have got first degree block, second degree block, and complete heart block. In first degree block, we have got a prolongation of the PR interval. Then in second degree block, we can have a fixed ratios of ventricular contractions. For example, we can have a 2:1 fixed ratio, a 3:1 fixed ratio. And these ones may be associated with anti-Rho, Sjogren syndrome, Sjogren syndrome, antibody A, that may cause a damage to the conduction system. This may also be caused by developmental abnormalities of the AV node. Then going on to tachycardias, I'll start with sinus tachycardia. This is an elevated elevated heart rate, but above 180, but it's usually below 200 beats per minute. It has got a regular rhythm, regular sinus rhythm, 1:1 ratio, atrial contraction to ventricular contraction. We've got maternal and also fetal causes. Maternal causes hypotension, which can be supine or due to hypovolemia. Anemia may also cause that. Maternal anxiety, hyperthyroidism, maternal fever, which can be systemic infections or chorioamnionitis, and also the use of beta agonists like salbutamol, terbutaline, and also stimulants like caffeine. On the fetal side, we've got fetal anemia, severe prematurity, prolonged fetal activity, and fetal distress or chronic hypoxia. Then on the management of, I'll just rush through the management of the sinus tachycardia. For sinus tachycardia, we have to identify the cause and treat it. We can then do weekly follow-ups for heart rate monitoring, and antiarrhythmic therapy is not indicated. I'll go on to short VA supraventricular tachycardia. The most common type, this is the most common type of ventricular tachycardias, representing 60% of the cases. It typically starts with a premature atrial contraction that conducts through the AV node with a retrograde conduction through an accessory electrical connection, initiating a re-entry circuit. So we've got an accessory connection. The heart rate usually ranges from 180 to 300 beats per minute. AV conduction is 1:1 with a short AV interval. They can be intermittent or sustained. If they are sustained, it means they are present more than 50% of the time. So this is an example of a short VA supraventricular tachycardia. We can see that the atrial contractions above the baseline there, they are occurring almost simultaneously as the ventricular contraction. There is a little delay there. So these are the accessory pathways that it can follow. We can have orthodromic, that is the anterograde conduction is through the AV node. Then we've got an antidromic where the retrograde conduction is the one that is through the AV node. Then we go on to long VA supraventricular tachycardia. This includes ectopic atrial tachycardia and permanent junctional reciprocating tachycardia. The permanent junctional reciprocating tachycardia is caused by an accessory pathway conducting retrograde from the ventricles to the atrium. but the pathway conducts more slowly as it tends to be more incessant. So from this graph, you can see that there's separation between the atrial contraction and also the ventricular contraction, which is a bit different from the previous one where we had a short VA, when the atrial contraction occurred almost simultaneously with the ventricular contraction. Then now we've got atrial flutter. So atrial flutter accounts for 30% of fetal tachycardias. The atrial rate is 300 to 600 beats with variable AV conduction. The previous ones, there was one-to-one conduction. On this one, conduction is variable. Ventricular rates may be normal to 330 beats per minute. So we can see on the graph there, if you look below the graph, we've got the atrial contractions. The rate there is higher than the rate that is above. We can have 1-2 beats before we can have a ventricular contraction. So some of the beats are conducted, but some of them they are not conducted. Then we've got ventricular tachycardia. This one is caused by abnormal depolarization originating from the ventricles. It's different from the supraventricular tachycardias, where the depolarization is initiated in the atria. Ventricular tachycardias can be caused by poor myocardial oxygen supply, inflammation of the heart, myocarditis, cardiomyopathy, or intracardiac tumors. The hallmark here is VA dissociation. There won't be an association between the contraction of the atria and the ventricles. So associated anomalies, there are fetuses with tachycardia should have a complete echocardiogram, as about 10% are associated with structural congenital heart diseases. So when we are scanning patients and we pick up arrhythmias, we have to refer to fetal medicine specialists for a specialized echocardiogram. This is because some of them may cause severe morbidity and mortality, and also the 10% are associated with structural congenital heart disease. That may be missed if we just ignore the fetal arrhythmias as benign. Ventricular tachycardia may be associated with cardiac tumors such as rhabdomyomas, anti-Rho and autoantibodies. A permanent junctional reciprocal tachycardia can be secondary to cardiac myopathies or aneurysms. And fetuses with tachycardias may also be closely monitored for hydrops fetalis. So we have to do a complete workup for our mothers with fetal arrhythmias. We have to order anti-Rho and antibodies. We have to also do our torches screen. And of course, the complete echocardiogram. So as for management, observation with frequent heart rate monitoring is reasonable if fetal tachycardia is intermittent. That is, if it's present for less than 50% of the time, and if fetal heart rate is below 200. And the principles of pharmacologic management include normalization of fetal heart rate, prevention of heart failure, and increasing duration of gestation to term wherever possible. As I said earlier, we have to order torches, we have to do anti-Rho and anti-La antibodies. So this is just an algorithm from the American Heart Association for the management of supraventricular tachycardias and also atrial flutter. For supraventricular tachycardia, we divide our patients into those with high drops and those with no high drops. So flecainide is the first line treatment for those without high drops. Then for those with high drops, we can then add digoxin. Then we go on to the second line, third line. If the third line fails, that is when we can do direct treatment. And in direct treatment, it includes transesophageal pacing, fetal transesophageal pacing, which is invasive. So these are the doses for flecainide, digoxin, sotalol, and amiodarone. So We should also monitor the mothers for development of adverse effects. So there is limited data in the literature comparing the efficacy and safety of multiple antiarrhythmic agents as first-line or second-line drugs. However, in a meta-analysis by Yu et al. Of 21 published retrospective studies, first-line monotherapy with flecainide or sotalol was superior to digoxin in converting fetal supraventricular tachycardias and atrial flutter sinus rhythm to sinus rhythm. In fetuses presenting with eye drops, this benefit was even more notable. Of note, transplacental treatment with digoxin. Digoxin, it passes through the placenta poorly, whereas flecainide and sotalol, they've got a good penetration of the placenta with high levels in the fetus. So with digoxin, we have to use even higher doses, which then puts the mother at increased risk of developing adverse effects. First-line monotherapy with flecainide was more efficient than sotalol or digoxin for treating atrioventricular re-entry tachycardia. In two recent publications, first-line treatment of fetal supraventricular tachycardia with flecainide resulted in conversion rate of 90 to 96% in fetuses without eye drops and 66 to 86% in fetuses with eye drops. On the other hand, sotalol with or without digoxin has been associated with higher rates of prenatal atrial flutter termination compared with digoxin or flecainide. As for the prognosis, in patients with tachyarrhythmias, eye drops fetalis occurs in half of all the fetuses. Overall rate of fetal demise is 9% in untreated cases. If treated by transplacental drug therapy, a rate of rhythm control is achieved in 80 to 90%. And 50% of the fetuses with supraventricular tachycardia will develop postnatal supraventricular tachycardia. So these fetuses will need to be followed up postnatally. Factors associated with increased incidence of postnatal supraventricular tachycardia include ventricular dysfunction, earlier estimated gestational age at delivery, and lack of conversion to sinus rhythm. So this highlights the importance of in utero treatment, which can actually prolong the pregnancy and also reduce the risk of developing postnatal supraventricular tachycardia. Atrial flutter is associated with good outcomes. It almost never recurs once the infant undergoes electrical cardioversion postnatally. So I'll go on to my case, and then the discussion after I present the case. This is a case that we managed at Salim Mugabe Fetal Medicine Unit. It's a case of Mrs. LR, who was 20 years old, housewife who lives in Glenview. She was para 2 gravida 3 at the time of presentation at an EGA of 29 plus 1 weeks. She came in as a referral from Glenview Polyclinic with an ultrasound scan showing a fetal tachycardia of 224 beats per minute, associated with polyhydramnios with an amniotic fluid index of 45, scalp edema, and pleural effusion of 19 millimeters. So the pregnancy was unplanned. It came about as a result of failed contraception. She was on control pills. She did not receive any preconceptional counseling. She just developed a nausea and vomiting, which was treated as a gastroesophageal reflux. And at the time, she wasn't aware that she was pregnant. The drugs that she was prescribed, she only remembers that she was put on paracetamol and other drugs she couldn't remember. She then did a urine pregnancy test after 3 months of amenorrhea, which came back positive. On a past obstetric history, she's got a history of eclampsia, which developed post-delivery in a second pregnancy. She also has got a positive family history of hypertension. However, there's no family history of cardiac disease or sudden death. She was not on any other chronic medications, iron supplements, or calcium. The patient is in her second pregnancy. She lives with her husband and 2 children. The firstborn child is from her first marriage. She does not take alcohol, smoke, tobacco, or take any recreational drugs. On examination, her temperature was 36.5 degrees. She had a blood pressure of 104 over 65 and a pulse rate of 96. The rest of a physical examination was normal. On the obstetric exam, the height of fundus was 31 centimeters. Lie was longitudinal and presentation was cephalic. She had a fetal heart rate of 220 beats per minute. On the ultrasound findings, the fetus was cephalic with a tachycardia of 244 beats per minute. It was in sinus tachycardia. Left-sided pleural effusion was noted. Skin edema, polydramnios of 11.9 centimeters. On examination of the ductus venosus, the airway was absent and it had high PI. The rest of the Dopplers were normal. No obvious structural defects or markers of chromosomal abnormalities were noted. The heart structure appeared normal overall. A diagnosis of supraventricular tachycardia was made. So this is the fetal heart, a picture of the fetal heart rate. We can see that the atrial contraction there is occurring almost simultaneously as the ventricular contraction. It was taken in the 4-chamber view, and okay, this one is also depicting the heart rate. On this picture, we can see fluid in the chest there, a pleural effusion of about 1.58 centimeters. Okay, this was a measurement of the fetal biometry. Growth was of the fetal biometry. This is the measurement of the head circumference. And this is the measurement of the amniotic fluid, showing polyhydramnios of deepest 4 of 11.94 centimeters, which is polyhydramnios. Examination of the middle artery, which was fairly normal, and despite the tachycardia, and this examination of the umbilical artery Doppler, which was also noted to be normal. So management of the patient was put on a flecainide 100 milligrams PO 3 times a day, and she was to be reviewed after 5 days for fetal heart rate monitoring. And mode of delivery recommended was a cesarean section. After 5 days, she came back for review. The fetus was in cephalic presentation. Fetal heart rate had normalized to 132 to 137 beats per minute. The left side, the pleural effusion was still present. Skin edema was noted. Polydramnios of 11.9 centimeters was noted. The ductus venosus A wave, which was absent, was now reduced with a high PI, and the rest of the Dopplers were normal. So here is the fetal heart. Here is the fetal heart rate. We can see the atrial contraction above the baseline there with our 2 waves. However, the E wave is higher than is looking taller than the A wave. Here we've got the umbilical artery Doppler, the middle cerebral artery Doppler. This is the ductus venosus Doppler. We can see the A wave is present there. And the pleural effusion in the chest, it persisted. The polyhydramnios also persisted, the deepest pool being 11.08 centimeters. So as for the outcome of the fetus, so unfortunately, she went into preterm labor at 34 plus 4 weeks, and she delivered by a vaginal delivery, and the infant succumbed to the condition, and she had early neonatal death. However, at the time of finishing my presentation, I had not gotten hold of the birth weight, the APGAR, the postnatal diagnosis, and the information about dexamethasone administration. Unfortunately, the mother was distraught, and when I talked to her, she was saying that she was still mourning the fetus, so she could not give me any information, any further information. I could not get a hold of her at the time of delivery. So unfortunately, I couldn't get the information on the birth weight, APGAR, and the other relevant information. So this is the end of my presentation. These are the references. These are my references. I'll give time back to the chair.
Okay, thank you, Dr. Mvundura, for the presentation. I'll leave this time for cardiologists, pediatric cardiologists, for their input on the case.
Good morning. My apologies. I joined the meeting a little bit late. Thank you for the presentation. Just started by saying that when the patients with fetal tachycardia develop eye drops, it becomes a bit of a problem because now you're trying to balance out how well they are going to be if you deliver them early, depending on the available neonatal facilities, how well they're able to manage a premature baby. And this is not just the usual preterm, but it's a preterm who's already compromised. So the issue becomes balancing out with trying to leave them in utero for a while versus to try and reduce complications of prematurity versus delivering them early to try and reduce the effect of high drops. If we're able to control the heart rate early enough, if they're able to be picked up early in the fetal period and there is good response, then that is good. But for some of the patients, the response may not be so well. You explained nicely, the presenter, on the types of tachycardias that we can expect in the fetuses. So most of the time, if they are missed in the fetal period, we do get quite a number of them in the first few days post-delivery. And the commonest rhythm we get in the neonatal period is the atrial flutter, which fortunately does respond very well to cardioversion. It could be electrical cardioversion with a defibrillator machine or medical cardioversion with adenosine. Their prognosis is usually very good. A few of them may need other antiarrhythmias to control the heart rate, but most of them do respond just to the initial cardioversion that would have been done. So just as an example, one similar case we had was around 34 weeks. At the time, there were severe eye drops, or rather, it was kind of worsening over time, so they had to deliver the baby. Post-delivery, fortunately, the neonatal unit was well equipped, so we managed to cardiovert the infant. They went into sinus rhythm, and within a week, a lot of those features of eye drops, the edema was subsiding, ventricular function was improving, pericardial effusion and the pleural effusion and ascites were also improving. So it's worthwhile to pick them up and make a plan on delivery, trying to balance out the benefits of early delivery versus the complications of prematurity. Thank you.
Thank you so much for the contribution. Do we have any other contributions?
Okay. Thank you very much, Dr. Mvundura, for a splendid presentation. Specifically for this case, I did not hear any comment with regards to, or probably I could have missed any comment with regards to the structural state of the heart. How was the heart like, the four-chamber view, the great vessels? Thank you.
Okay, thank you, Dr. Zluayo. So the heart structural, it looked normal on when the fetal echo was done.
Thank you so much, Dr. Mvundura.
Okay, there's a question. Oh, okay, yes. Over to you.
Thank you, Chair. So my question, I think what Dr. Madembo is trying to highlight is that probably a detailed description of the fetal echo should have been made, because we are dealing with a specific organ system in this particular case where the cardiovascular system examination is to be detailed. Then the second issue is, you mentioned that the parents were distraught. Were the family therapists involved in the care of this case? Because what you highlighted there is quite worrisome. If they were, I think they're in this meeting. If they were involved, maybe they can tell us what is their progress in terms of helping this woman in this difficult time. What did they do to her, and so forth? They can give us their input. We should never forget that we work with family therapists or fetal medicine counselors, and in your presentations, you can't blind side them, kind of, because they're part of the care plan in this kind of very high risk cases. So if they are in the meeting and if they were involved here, we want them to give any input. Then the question to the pediatric cardiologist, do you think we could have used dual therapy? Was flecainide good enough? Yeah. Or we could have probably added more medications. Thank you.
Thank you for the question, Dr. Verenga. Sorry for jumping in. I'll need to be leaving soon. I was thinking that probably the fetal heart could have responded from, I'm not sure if I got them correctly, that it had come down to around 132 to 170 something on the follow-up. But in cases where there's no response, then dual therapy would be needed, though we'll be looking at probably more side effects towards the mother. I was also wondering at 34 weeks, if the hydrops was severe, maybe an option would have been to try and deliver by Caesar. I'm not sure if the outcome was going to be better, but when the features of eye drops are a bit advanced, sometimes if the neonatal facilities allow, probably delivering may possibly could have been an option depending on the circumstances. Thank you.
Thank you so much for the question and the answer and the contribution. Do we have any other follow-up questions? In the meantime, there's a question from Mr. Kumbula. Under fetal causes of tachycardia, are there any other specific non-cardiac fetal conditions that may coexist from tachy apart from the anemia? Over to you, Dr. Mvundura.
Okay, thank you. So other causes of fetal tachycardia include fetal distress. They include fetal distress, fetal activity, besides the fetal anemia, and
All right. So, sorry, through the chair, I think we're broken in terms of communication there. I just wanted to follow up if the family therapists are here. I'm just concerned that I didn't see their involvement here. Were you guys involved in this case? Because it will be a concern to, because this is not how we should practice fetal medicine. Patients should always be counseled by competent people whenever they are through this, going through this situation. So were the family therapists or fetal medicine counselors involved? Dr. Mvundura, or maybe we've lost him. Does anyone know, are the family therapists in the meeting?
Yes, I am.
Would you want to answer, please, for the sake of time, what your role was, so that we, and because you mentioned, because fetal medicine does not end because the baby has been delivered, but we heard that the mother is suffering at home. So that's my concern to say, were you guys involved?
On this patient, I wasn't involved. I missed it.
But any of your team, were they involved? Because all patients with defects have to be seen by fetal medicine counselors. Were you guys, was anyone involved? Kind of.
I'm not so sure. I will confirm.
Okay. If not, then I think it's important that you get in touch with the woman and try to help her. Because
Okay,
it's quite concerning. And also, I think for the teams, I think it's important. I know the temptation has always been there because it's tradition. That's the traditional to say doctors, they want to be everything and all when managing to patients, but we need to recognize our limitations. That whatever information we give clinically has far-reaching effects, including mental and psychosocial impact on patients, which is a field that we are not trained to handle, or which is beyond us. To say what will this do to this couple's mental health, psychosocial issues. So we should always engage counselors in all the difficult cases that we come across, so that they can help us to address those kind of areas. We are not trained specialists in handling that area. I think I can see maybe Make wants to come in. She is raising her hand.
Good morning, everyone. Thank you, Dr. Enga. Just to add that at PARI, we have managed to ensure that even if a family therapist, counselor, or psychologist is not available, it's important for the attending practitioner to write in the notes so that this patient does not go home before she gets the therapy involved, because we've seen sometimes it leads to complicated and unresolved traumas and grief, and also in some very few cases, suicidal ideations. So maybe it might work for Sally as well.
Thank you. Thank you so much for that input. My last question is, why wasn't the care plan followed? Because it was clearly documented on first appointment that she should be delivered by C-section. Do we know why when she went into emergency mode, which was preterm labor, why was vaginal delivery allowed to proceed? Do we have an idea, Doc, from the notes?
Yeah. So I'm yet to get hold of the notes. I just talked to the patient, but I'm yet to get hold of the notes. After I get hold of them, I'll update you, because the plan was the recommendation from FMU was documented. The recommendation for cesarean delivery.
All right, great. So point noted, but maybe remember for all the defeat cases, all the registrars, remember to get the contacts of the ladies you are following up, and please tell them to contact you when they are in trouble or they get into labor, so that their care plan is assisted, because there's no point in identifying them. Then when they come into labor, we are not aware that they are now in labor. So let's try to improve there, to make sure that we get the contacts, and these women, we told them exactly that if something happens to you that you are going to labor, they send you a message so that you are on top of the issue, because we want to know the real outcomes or the robust outcomes, say what exactly happened to these cases who are being identified in uterus. Otherwise, the advantages of prenatal diagnosis falls away if we disengage where the outcome matters. So we do not want to disengage. We want to continue engage with the patient all the way. We don't get disengaged because they've walked out of the unit. So I think we need to fix that, so that patients who come, we exchange numbers with them, we follow them up, we give them explicit message to say, please get in touch with us. As soon as labor starts or something happens to you, just text us so that we can assist in the care pathway. That will help us to know, because most of the information that we need to know is missing because we're not involved or we're disengaged, kind of. Thank you.
Thank you, Dr. Wirenga, for the contribution. Do we have any other contributions? I don't see any other comments. So thank you for attending this meeting. Till we meet again next week. Thank you.